mobility. Ginny did the slides, but I thought she took mine and combined them, but she didn't quite do that. Her slides are great at the beginning, but I have a lot more for MS and Parkinson's, so I did make copies. As soon as I'm done, I will post them, because I noticed a lot of you like to have the full slides. So, wait, two back there? You want to send these two back? Anyone else? Anyone else has them? Leave a couple up here if anyone wants it. No, it's different. It's different from what's... Yeah, so anyone else? Okay. All right, so the concept is mobility. The interrelated concepts: comfort, development, grief loss, self, safety, and quality. So you've seen, I'm not going to be objective, you can see, the concept mobility since 1000. And, you know, a lot of people would look at, well, how does neuromuscular MS and Parkinson's fit with mobility? But basically, the musculoskeletal system is all controlled by the nervous system. So they go hand in hand. So, you know, mobility, yes, could be that gross movement, fine movement. But basically, someone who's unable to move, it could be because it's skeletal, could be because it's muscular, could be because it's neuro. So all of them could affect the mobility system. And again, so one of our whole thing as for nurses, looking at you providing nursing care for someone who does have an impaired mobility. So again, purposeful movement depends on the musculoskeletal system, the nervous system, and again, that they work hand in hand. So adequate energy, adequate muscle strength, stable skeletal joint function, and neuromuscular coordination. So again, just going through the concept first, mobility plays an important role. It really does everything we do. You know, and if we don't have mobility, you think of some of the people who are disabled, you know, from neuromuscular, cerebral palsy, multiple sclerosis, spinal cord, or even if any of you have had a fractured leg and arm, how it affected you in the things that you were able to do. You know, you fracture your dominant arm, and all of a sudden, you go into the men's room, ladies' room, and sit there and say, uh-oh, I'm so used to doing everything with my dominant hand, and you got to relearn to do things. But it interferes with ADLs, work environment, home environment, sports, fun, and interaction with other people. If you don't use the muscles, that's what this disuse syndrome is. You lose strength and you lose muscle mass. 10 to 20% decrease in muscle strength per week if you don't use it. And again, muscle mass, 3% loss within thigh muscles in 7 days. So again, you see a lot of the muscle mass in some of the bigger muscles, the weight-bearing muscles. You definitely see anyone who's worked with spinal cord injury patients, you know, their legs tend to really start to atrophy, what we call disuse syndrome. So they lose a lot of that muscle mass and strength. So scope of mobility, from complete mobility to incomplete. As nursing students, you'll be getting out how to care for patients along the continuum. From partial mobility, maybe they're able to do active range of motion, getting up as soon as possible. Maybe someone who's complete immobility, maybe we have to do passive range of motion. Maybe someone who's immobile, we need splints, cast, amputee, prosthesis. Population at risk as we increase in age, certainly affecting our skeletal system, our porous bones, osteopenia, osteoporosis, arthritis. But again, it could be acute chronic conditions, and especially if it's a skeletal system and arthritis, a lot of pain involved. Psychological process, for physiological process, again, I already talked about the skeletal, muscles, ligaments, cartilage, all important, but again, this is where we're going to concentrate the neurological system being both the MS and Parkinson's. Consequence of immobility, this you've had since 1000, 1020, post-op, all of those things, from respiratory, having decreased, reduced lung expansion, problem, could be atelectasis, pneumonia, cardiac, decreased cardiac capacity, skin breakdown, constipation. They're at increased risk of having renal stones, and again, if the urine stays stagnant, have an increased risk of infection. And it's psychological effect. Especially if somebody's used to moving around, doing things, and all of a sudden they can't. And I don't care whether it's from a fractured leg or spinal cord, there seems to be some type of their status has changed. And again, from maybe boredom to maybe something more, hopelessness, depression, so all the psychological support that we have to do. So that's the consequence. So as nurses, yes, you're going to assess mobility status, history, what have they had in the past history with mobility, any issues against maybe posture, their gait, get into neurological assessment and diagnostic assessment. For the neurological assessment, again, level of consciousness. Are they alert? Are they oriented? Are they awake, comatose? Pupil assessment, pupils equal round, reactive to light and accommodation. Cranial nerve testing, vital signs, motor function, sensory function, tone, cerebral function, all of that part of the nervous system. This is just a reminder of the cranial nerves. I'm telling you right now, I'm not testing you on cranial nerves. It just belongs with the neuromuscular assessment. But when I say that, when we get to Parkinson's and multiple sclerosis, your cranial nerves are part of the nervous system. So many of them are going to have problems with vision, maybe double vision, maybe facial movement, because some of those nerves could be affected. But again, it's basically just an FYI, and this as well. Actually, Ginny put this, and I left it here. So when you're studying for NCLEX, I'm telling you right now, there will be no cranial nerves on the test. But just, if you want to remember where they are, 1, nose, eyes, 3, 4, 5, 6, 7, 8, ears, 9, 10, 11, and 12. So just another way to visually try and remember where all the cranial nerves are. So another part of the neuromuscular assessment, neuro assessment, is Glasgow Coma Scale. Will it hit test number 1? No, because it really doesn't pertain to MS and Parkinson's. But yes, you will have this. This will come back to you again in head injury. Because basically, it assesses people's level of consciousness, eye-opening, speech, and motor functioning. So again, I'm not going to really get into it too much, but the best score is 15, so someone can open their eyes spontaneously, they're oriented, and they obey, they can move their arms and follow you, they would get a 15. And then the lowest is 3. that they cannot open their eyes, that they're not talking, and they cannot follow directions. So again, usually you'll see people with brain injury, they do a Glasgow Coma Scale to everyone. Anybody use Glasgow Coma Scale in their setting? Would you?
EMS.
Okay, EMS, absolutely. So on the scene,
Less than 8, we have to call for ALS.
got it, perfect.
Yeah.
Anybody else? So, because one of the earlier class, they said they were at the VA and they did it every week, and I was surprised, and I said, what was your population? They said it was a spinal cord injury floor. And I said, was your patient multi-trauma? And they said, no, alert and oriented. I said, I've never used the glass. It's not really meant to be used on every person, because if you have a spinal cord alert and oriented, they're opening their eyes, they're oriented, and they're obeying commands. Even though they can't move their legs, but they can move their upper, whatever they can move, they can. So they would be at 15, so I'm not sure why they were doing it. And, so they said maybe the clinical faculty just wanted them to do it. So other thing part of the neuro exam is posturing. Again, just remembering the different postures. And you do tend to see this against somebody who has issues with the brain. So again, could be spinal cord, multi-trauma, the brain involved. But again, the decorticate, and again, looking at that C, is they have the flexion and decerebrate, the extension. If you want to try and remember the difference, I look at sometimes decerebrate, just, that your arms are extended. So, this looks more like decerebrate to me, so they're celebrating. So just trying to remember the difference of the two. So we're not hitting all of these. These are some of the exemplars that we could use for impaired mobility. And basically, congenital, you could say pediatrics. Did you go over that in pediatrics?
Yeah.
Yeah. So again, that would be something, impaired mobility. I would say, and again, we're not going to test, I'm not testing on these, just to show you some of the disorders that can cause impaired mobility. When I think of spina bifida, it's probably one of the populations for an infant that I may have to lay prone. I have to put them on their side or lay them prone so I don't put any pressure on, the sac. As far as skeletal conditions that can cause impaired mobility, amputation, fractures, osteoporosis, spinal cord injury, herniated disc, neuromuscular, amyotrophic lateral sclerosis, ALS, where they become a prisoner in their body, cerebral palsy, again that tends to be more the spastic neuromuscular disordered, Guillain-Barré, that's a paralysis that starts from the ground, goes to the brain, and again, because it's peripheral nervous system, they can regenerate and improve. Multiple sclerosis, we're going to talk about today. Myasthenia gravis, weakness of the upper body, and Parkinson's we're going to talk about. But when I see a lot of these neuromuscular and their problems with the impaired mobility, most of them, my major concern when they have my priority, yes, respiratory, if they have an exacerbation, respiratory, and Parkinson's takes a little bit longer, but certainly it could, but most of the neuromuscular, we're always concerned if they have weakness around the thoracic cavity, they could have problems breathing. And other exemplars, joint and connective tissue, sprains, joint dislocation, and gout. So that basically is just an intro, or you probably have seen it before, of just the concept.